Professor Umpierres for setting the stage on the importance of prevention of GDM. I'm going to do a talk that I'm actually doing it for the first time, which is it time for gender-specific guidelines in diabetes care? And it's particularly, I think I'm very grateful that Professor Umpierres is here because he's in the writing group for the ACE guidelines. So first I want to, it's like a disclaimer, this is not a battle of the sexes, men versus women, who's more important, no such thing. It's actually only about, it's an effort to sort of make women fully visible to when we take care of them, all their challenges, and so making them fully visible and being gender aware is the essence of this presentation. So one of the reasons that I wanted to do this talk was I'm a big fan of the Go Red for Women program in the US, which was launched in 2003, which is a program for the heart health of women. And what they have found after this 14 years or so is a remarkable difference in the outcomes. There's actually like 34% fewer deaths in women, and actually a graph that was going like this has been changed. This was women and this was men. Now this is men and this is women. So they're actually talking about a Go Red for men. So as you can see there, it's to have more gender-specific, gender-specific approach is, I think, how they were able to achieve this success. And maybe there are lessons to be learned from this kind of a program in the US. So what is gender, diabetes, and women? What does this include? First, I want to say the experience of diabetes is different in women. And diabetes is definitely more serious outcomes in women, that we know. And the life cycle of women is different. We always talk about lifestyle, but life cycle is very different in women, and that has to be factored in. And the socio-economic and cultural context and other social determinants of health have to be factored in, particularly when we are talking about women. And gender-specific research and also sex-specific reporting of findings. For the longest time, women were not included in many of the big research projects, but I think that has changed now. And gender inequities in healthcare that we are all aware of, and the need to view therapeutics with a gender lens. I'll show you a couple of examples, and gender mainstreaming, what that means and benefits. So we're talking about should we be having guidelines, and what do guidelines mean and what do? They actually provide a critical appraisal of the existing evidence for us. A roadmap is available for the provider, and there is some ease of decision making, and it's validated by professional bodies. It's a reference document for consultation, standardization, and it's been shown to improve outcomes. So I think that's the benefit of guidelines. But we always have to keep in mind that guidelines are guidelines. So first I want to establish something that we always confuse gender with sex. Sex differences are not the same as gender differences. So as you can see here, sex differences are biological differences. Gender differences take into account social and behavioral and other factors. And there's a lifelong interaction between sex and gender in development and outcomes of diabetes, as you can see, between sex and gender and epigenetic modifiers, as you can see, from the beginning all the way till the patient develops type 2 diabetes. And then there are also significant physiologic and pathophysiologic sex differences in people, men and women, and which affects what happens in terms of diabetes, the presentation, how it happens, and also in terms of how we are going to manage them, how they are going to respond to treatment. So this is a very important thing to keep in mind. Many, many differences are present between the two of them. Women have less impaired fasting glucose, more impaired glucose tolerance. What about the scope and the risk and the complications itself? This is just numbers for women. From 143 million in 2010, we have gone now in 2017, the new atlas says that we are somewhere around 203 million, and it's projected to be about 313 million by 2030. But I can tell you, we will cross those numbers even before 2020 or maybe by 2025, because usually projections have been like that. The IDF in there, I do not know if they have a crystal ball. So when in this picture, actually they've put in something like 7 women out of 12 people. So are they expecting more women to have diabetes in the future? Probably. And the reason that women are likely to outnumber men is because PCOS is increasing. You know that GDM is a risk factor for future type 2 diabetes, and pregnancy itself, and obesity and menopause and increased numbers of pre-diabetes in women. Abdominal obesity and generalized obesity are more in women in our country, as you can see. And for the same BMI, women have more diabetes than men. That is also established. Very, very important to keep in mind that women have these challenges with weight. And pre-diabetes is more, and this is the CARS data, whether it is Chennai or whether it is Delhi or whether it is Karachi. In Chennai it is more, in other places it's almost equal. So this is a serious concern because it gets converted to diabetes down the road, and these are young people. Pre-diabetes is higher in women at a younger age. So what are the other risk factors in terms of adverse outcomes? Women seem to have much higher risk of heart disease compared to women who don't have diabetes, and even compared to men seem to have much higher risk of heart disease. The same thing goes for stroke. Stroke is not something that's usually it's not something that's in our radar. So we've started talking to people about heart attack and brain attack being two important things, and this way more importance is given to blood pressure and importance is given to the prothrombotic milieu. So the excess risk of stroke is associated with diabetes is significantly higher in women than in men, independent of sex differences and other cardiovascular risk factors. So all this translates into increased mortality. You take every continent, I think except North America, what we have found is an increased risk of mortality in women compared to men. So all this translates into that. Then there is the socio-cultural and economic context that I mentioned. We need to factor in what does the patient want. When it comes to a woman, she may have other genuine, serious concerns. What is this going to do in terms of my ability to get married? Will I be able to have children? Will I be able to afford these medications? What does this mean in terms of my caregiving responsibilities that I have for the family? So her own thinking are going to be very different. And just want to show you, this is data from India. It's about 10 years old. But if you see here, financial dependence for care, and this is people with diabetes, and significantly you can see that women are more dependent on their spouse or on their children for medications and for the financial expenses. So this means that we have to be even more careful about what we are prescribing to our women patients. Take into account that they may not be able to afford those medications. And in this other big population-based outcome study conducted in a large group of diabetic patients between the ages of 45 and 64 and members of a very large health maintenance organization. This was in Israel. And you can see significantly lower healthcare utilization was actually observed by men compared with women for all indicators examined. However, men showed better health outcomes, lower low-density lipoprotein, triglycerides, and A1C. So they seem to be using the less health-seeking. They may be, undergoing the test, but in terms of outcomes, the men seem to do better. Is it because women are not prescribed the same kind of medications, maybe the same kind of follow-up, or is it because they themselves put their health low on the priority list? So this is very important. And then there are also gender differences in functional limitations in adults living with type 2 diabetes. So they said, although women seem to have had a better diet and blood glucose self-monitoring behavior than men, they reported less favorable body mass index and glycosylated hemoglobin. So this HbA1c A1C shows up in both these studies, which means less outcomes in terms of good control. I want to present two clinical situations just to highlight the differences. So both of these patients are newly diagnosed diabetes, Amit and Archana. They both have an A1C of 8.2 and both have a BMI of 28. Both get started on vildagliptin and metformin, 50/500 twice a day. The given lifestyle modification taught home glucose monitoring. Both have been treated exactly the same. That's good, and they're following the guidelines. Okay. 2 days later, Archana calls you and says that she read in the package insert that vildagliptin is not safe during pregnancy. And she's actually thinking about having another child. That was never factored into the discussion when the physician was prescribing the medication to her. Or think of it in a more dramatic way. What if she calls you 7 weeks later and says, I just missed my menstrual cycle and found out that I'm pregnant. Should I have been taking a medication that was not safe for me? So this kind of keeping in mind the life cycle of women, the person to whom we are prescribing the medication, I think is critically important. Let's look at another, and we just heard a brilliant talk by Dr. Mithil. So this is a 64-year-old, Padma and Subhash. Both have type 2 diabetes for 6 years, and both have an A1C of 8.9. They are an SGLT2 is added to existing therapy of sulfonylurea, metformin, and DPP-4 inhibitor. So that was also, I think, they're following the guidelines. So what happened to these patients? So Padma has a fracture 9 months later of her hip. And because she underwent surgical menopause at the age of 42 and known to have an increased risk for osteoporosis. So before we prescribe any medication to a woman or to a man, I think it's really important to take into account their health history and what they are at risk. And this is particularly significant for women because we go through things like pregnancy and menopause and increased risk for bone loss and fractures. So this is important to keep in mind, and also may have may not have economic independence. Also want to bring up another important point. To investigate the effect of gender on catecholamine response to hypoglycemia, a single-step euglycemic hypoglycemic clamp study was done, and what they found was catecholamine responses to moderately controlled hypoglycemia was diminished in women. So when we are prescribing therapies that may potentially cause hypoglycemia, something to keep in mind, and also more importantly for things like women may do more fasting, may eat later than other members of the family, may not actually get enough to eat after everybody has eaten. So when prescribing agents that have a potential for hypoglycemia, this is something to keep in mind. So just want to mention that the ADA guidelines for the anti-hyperglycemic therapy goes through the different steps of starting with one agent, which is metformin, and then adding a second set of agents or a third set of agents, and then going on to basal insulin therapy. And even though they talk about approach to management of hyperglycemia in a patient-centric manner, I know that these are all having a range and a spread, and gender is very, we're talking about men and we're talking about women. It's really important, though, to keep that in mind. Somewhere that has to be factored in. How they will do it, we'll have to figure out. And as far as the ACE guidelines, again talks about a whole list of 10 points, talking about lifestyle modification, avoiding hypoglycemia, avoiding weight gain, which again is very, very important when using agents for women, because women constantly struggle with weight. And I also mentioned for the same BMI, there may be higher amount of diabetes. So individualizing the glycemic targets, optimizing the glucose, therapy choices based on diabetes, obesity status, and then they go through that list, but somewhere I'm not able to find the importance of taking, the reproductive cycle and other concerns that women may have into that. maybe it is in small print somewhere, but I think that should be in big print so that we can bring it into the radar of the practicing physician. And again, when we look at the glycemic control algorithm, somewhere if we have a red flag about agents that may be potentially harmful if used in the reproductive age, because we are seeing younger and younger and younger people with type 2 diabetes now. We are seeing women in their 20s and in their teens and in their 30s when they may still be in their reproductive phase. So it's important to keep that in mind. And we may use metformin, and that may actually trigger ovulation in an unsuspecting individual. We may use an agent that may actually be unsafe in pregnancy. We may use an agent that may cause hypo in a person who's not eating till much later in the afternoon. Or we may use an agent that increases their risk of osteoporosis or fracture, or their risk of weight gain. So I'm just saying that we need to put in those filters as well when we are talking to a woman with diabetes. Again, in these profiles of anti-diabetic medications, I think it's a wonderful list of the profile, but somewhere I think if we can add also pregnancy, it'll be really important, really good. So one of the things I already mentioned about the Go Red for Women being a gender-based approach, a success story, and I think when we take something like this and make a lot of noise about it and bring it mainstream, it grabs the eyeballs and the attention of people. And probably more attention is paid not only by the practitioners, but also by the community, the women in the community who will start taking better care of themselves. So anything new we know is the diffusion of innovation theory. I really hope that people hear, and I really appreciate Neeta for giving me an opportunity to talk about this. I think there are many change agents in this room. We have to become early adopters of this, and hopefully this will become standard of care very, very soon. I'm a very big fan of Professor Harvey Cushing, and I really wished I lived 150 years ago when he was around. He said, a physician is obligated to consider more than a diseased organ, more than the whole man. He must view the man in his world. Of course, this is not gender sensitive ways he has said. He's talked about man and he's talked about he, but that was then. But I think now, but the principle of this, we need to take into account not just the overall, the disease, but actually who has it, and what is their, the world around them before we decide on the treatment for them. So lastly, I just want to say, gender mainstreaming, what does that mean? Gender mainstreaming means that any work on diabetes, whether it is research, data collection, policy development, advocacy, information activities, program development, interventions, including treatment, services, monitoring, must always take into account relevant gender perspectives. Consider the situation and the needs and priorities of both men and women. So when we're talking about gender, I'm talking particularly about women, but it's really important to take into account men and women. And because women's life cycle is very different and leads to multiple different complications throughout her life, we don't want to add other layers of complications or complexity to her already complicated life by prescribing something that's not good for her. And I think maybe we can improve the outcomes by prescribing something that is good for her. So I want to end my talk by saying one size does not fit all, and diabetes in women probably is not the same as men, and we just need to be a little bit more gender aware. Thank you.